Happy World Coma Day. My name is Ariane Lewis. I'm the Director of Neurocritical Care at NYU Langone Medical Center. Today I'm going to be speaking about what is coma. A survey of the general public in the US that included 206 respondents assessed their knowledge and perceptions about coma. It demonstrated that 143 respondents focused on the state description, meaning focusing on unresponsiveness and unawareness when a patient is comatose. 66 respondents focused on the distinction or lack thereof between coma and brain death or sleep. 60 respondents focused on markers of injury severity associated with coma, including danger, permanence, and the need for life support. A very small number of respondents, only 8, focused on the potential for covert consciousness associated with coma. Members of the Neurocritical Care Society were surveyed about their perspective on the cardinal features of coma. There were 252 respondents. 81% of respondents indicated that absence of wakefulness was a cardinal feature of coma. 64% of respondents indicated that a Glasgow Coma Scale, which we'll talk about further later, less than or equal to 8 is required for coma. 60% of respondents indicated that failure to respond purposefully to visual, verbal, or tactile stimuli based on clinical exam is a cardinal feature of coma. 58% of respondents indicated that inability to follow commands, with the exception of patients who are aphasic, is a cardinal feature of coma. 53% of respondents indicated that no eye opening is a cardinal feature of coma. 49% of respondents indicated that no visual pursuit of objects, fixation, or saccade to stimuli is a cardinal feature of coma. 44% of respondents indicated that no evidence of cognitive motor dissociation or covert consciousness based on the neurophysiological studies or functional imaging is a cardinal feature of coma. And 43% of respondents indicated that no intelligible speech or recognizable gestures is a cardinal feature of coma. The Curing Coma campaign created a consensus definition of coma, which is the absence of sustained spontaneous or stimulus-induced arousal or wakefulness in the setting of absence of paralytics, sedatives, or another neurologic or psychiatric disorder. Coma is characterized by patients only demonstrating reflexive motor responses, having no visual pursuit, fixation, or saccades, no command following, intelligible speech, or recognizable gestures, and if advanced studies, including EEG or functional MRI, are done to evaluate for covert consciousness, for a patient to be considered to be in coma, there can be no evidence of covert consciousness. Members of the Neurocritical Care Society were surveyed about their perspective about this definition. In terms of each component of the definition, 50 to 60% of respondents strongly agreed that this component was required for coma. However, about 1/4 of respondents strongly disagreed with each aspect of the definition. There are a number of different potential etiologies for coma, including traumatic brain injury, which could be a subdural hematoma, epidural hematoma, or intraparenchymal hemorrhage, leading to swelling and bleeding in the brain, stroke, infection, neoplasm, so various types of tumors, again associated with swelling and brain compression, can lead to coma. Hydrocephalus, demyelinating disorders, status epilepticus, and anoxic brain injury are all other sources of neurologic etiologies for coma. Systemic problems can also lead to coma. For example, cardiac arrest or hypoxic respiratory failure or hypercarbic respiratory failure can cause coma. Uremia or hyponatremia can lead to coma. With respect to the gastrointestinal system, liver failure can cause hepatic encephalopathy, which in the most extreme case can lead to coma, as can vitamin deficiencies. Severe infections prompting sepsis can lead to coma. Thrombotic thrombocytopenia or hypo or hyperthyroidism or hypo or hyperglycemia can lead to coma. And then finally, toxins, including alcohol, benzodiazepines, opiates, or other drugs can cause coma. Members of this Neurocritical Care Society were surveyed about their perspectives on the most common etiologies for coma in terms of what they had recently seen amongst patients. Members responded that the most common etiology was intracerebral hemorrhage, followed by traumatic brain injury, spontaneous subarachnoid hemorrhage, cardiac arrest, ischemic stroke, and status epilepticus. Less common etiologies for coma included sepsis, encephalitis, a subdural hematoma, a brain tumor, autoimmune disorders, demyelinating disorders, vasculitis, and then much less were inborn errors of metabolism, paraneoplastic disorders, or genetic disorders. There are a number of different tests that can be done to evaluate patients in coma to understand coma etiology. With respect to labs, these include electrolytes, liver function tests, a CBC, an alcohol level, a serum and urine tox screen, arterial blood gas, troponin, blood cultures, urinalysis, urine culture, ammonia, and TSH. Other studies to evaluate coma etiology include a CAT scan of the brain, an EEG to evaluate for subclinical seizures, a lumbar puncture to evaluate for infection or demyelination or blood in the cerebrospinal fluid, and an MRI. When asked about the diagnostic assessments that members of the Neurocritical Care Society perform to evaluate patients with coma, the most commonly performed assessment is the neurological exam. This is followed by a CAT scan of the brain, basic laboratory studies, an MRI, continuous EEG, and a lumbar puncture. Other tests that were noted to be employed to evaluate patients with coma included various tests to assess intracranial pressure, including placement of an external ventricular drain, placement of a bolt, or doing non-invasive evaluation of intracranial pressure via optic nerve assessment of optic nerve sheath diameter, or other techniques. Other assessments that can be used to evaluate patients who are comatose include FMRI, as was discussed previously, to assess for covert consciousness, and we'll go into more detail about that shortly. SPECT scans or PET imaging, depth EEG electrodes, or microdialysis. The basic clinical evaluation of patients who are comatose can be quantitated using two different types of scales. One is the Glasgow Coma Scale, and the second is the FORCE score. The Glasgow Coma Scale is a 15-point scale that evaluates eye opening, verbal responsiveness, and motor response. The lowest score that a patient can achieve is a 3, 1 point for each of these subsets of the score. The highest score, as I mentioned, is 15. The FORCE score is another evaluation that quantifies the neurologic assessment based on eye movements and opening, motor score, brainstem reflexes, and respiratory pattern. However, these two types of evaluations are crude assessments in terms of the evaluation for consciousness, as there are a number of behavioral signs that can be evaluated to look for consciousness. This chart shows these and some examples of these behavioral signs, including resistance to eye opening, evaluation of spontaneous eye blink rate, grimace, response to auditory startle, sniffing if something is placed in front of the nose, oral feeding or swallowing if something's placed in the mouth, leg crossing, or localization to sounds. Because it's important to consider more advanced behavioral signs to evaluate for consciousness, the Glasgow Coma Scale can be supplemented with the Coma Recovery Scale Revised. The Coma Recovery Scale Revised can detect 40% more patients with consciousness than the Glasgow Coma Scale. The Coma Recovery Scale Revised includes a much more detailed evaluations of patients' responsiveness. For example, you can see in the image here, this provider is evaluating the patient's consciousness by seeing whether or not the patient will track when a mirror is placed in front of his face. One step more in terms of being able to evaluate for consciousness is through use of FMRI, which can evaluate for covert consciousness. The FMRI can evaluate for covert consciousness by asking a patient to conduct a task and watching to see the response that you see on the FMRI. So here in this image, you can see that both a patient and a healthy volunteer were asked to imagine that they were playing tennis. In this case, the patient was unresponsive in a comatose or vegetative state. Both the patient and the healthy volunteer have activity in the same area of their brains. Similarly, the patient and the healthy volunteer were both asked to imagine that they were performing a spatial navigation task. In this case, imagine that they were walking around their homes. Again, you can see that the activity shows up in the same areas of both the patient and healthy volunteer's brain. This demonstrates that the patient had covert consciousness that was not able to be detected on the bedside evaluation, but could be detected via use of the fMRI. EEG can also be used in this manner to assess for covert consciousness. Here you can see the brain of a healthy volunteer and a vegetative patient. And both this patient and the healthy volunteer showed similar activity in the same regions of the brain, again, when asked to perform a motor imagery task, demonstrating the patient had covert consciousness. Use of instrumental evaluation by around the world varies. This study looked at members of the International Brain Injury Association, most of whom take care of patients in the post-acute or chronic setting, and evaluated their use of different types of instrumental evaluation. You can see that their use was different in different parts of the world. For example, with respect to use of an EEG, countries outside of North America or Europe, 64% of respondents indicated they used this test, whereas in North America, only 30% of respondents used this test, and in Europe, only 44% of respondents used this test. There were also significant differences around the world in the use of evoked potentials, event-related potentials, MRI, and functional MRI amongst respondents. The recommendations for use of instrumental tools to evaluate patients with disorders of consciousness differs around the world. The American Academy of Neurology recommends that fMRI or electrophysiology studies may be used if there is ambiguity about evidence of consciousness. The European Academy of Neurology notes that fMRI should be considered for patients without command following at the bedside. Further, they suggest that quantitative analysis of high-density EEG be considered to differentiate a vegetative state, unaware wakeful state, from a minimally conscious state. Finally, the Royal College of Physicians notes that it is not clear that advanced electrophysiology or imaging techniques have diagnostic utility over expert neurobehavioral evaluation. Patients who are comatose can either recover, progress to a vegetative state unresponsive wakefulness syndrome, or progress to a minimally conscious state. The vegetative state was first described by the American Academy of Neurology in 1995. It was noted that about 10 days after coma onset, patients can reacquire the ability to open their eyes. Patients in the vegetative state have a lack of awareness of self, of the environment, though they do have preserved sleep-wake cycles. They demonstrate variable preservation of cranial nerve function and non-purposeful or reflexive movements only. In this initial description of the vegetative state, it was noted that this may be temporary or permanent. A persistent vegetative state was described as a vegetative state that lasted more than 30 days. A permanent vegetative state was described as a persistent vegetative state that is believed with a high degree of clinical certainty to be irreversible. The minimally conscious state was described in 2002 as a patient who has partial preservation of consciousness, and could reproducibly either follow commands, gesture or provide yes/no responses, vocalize intelligibly, or exhibit purposeful behavior. Additionally, in the minimally conscious state, patients can localize to sound or noxious stimuli. They may reach for objects. The minimally conscious state can be temporary or can be permanent, so patients can recover from the minimally conscious state in some scenarios. It's important to recognize that the minimally conscious state may be misinterpreted as a vegetative state. In fact, some studies suggest that up to 15% of patients who are considered to be in a vegetative state are actually in a minimally conscious state, but additional evaluation was not done to make this distinction, because it's also important to recognize that patients in a minimally conscious state can have fluctuating level of consciousness at times, and so can appear as though they're in a vegetative state when in fact they do have some awareness and responsiveness. However, it's important to note that the dimensions of consciousness are actually much more complex than was previously thought. There are many more aspects to disorders of consciousness than coma, a vegetative state, and a minimally conscious state. As you can see here in this diagram created by Dr. Edlow and Dr. Joe Finns, when considering disorders of consciousness, while we have a coma as one type of disorder of consciousness, there are many other states that can be described along the spectrum of disorders of consciousness. And when making this description, it's important to note whether overt cognition was only be assessed, or whether there was an evaluation done for covert cognition via FMRI or EEG. In thinking about covert consciousness and its detection via fMRI or EEG, studies of the literature were done to assess how often this was present. First, it's important to note that covert consciousness has a number of different synonyms, and in the literature is described using different terminology, including covert awareness, cognitive motor dissociation, functional locked-in syndrome, non-behavioral minimally conscious state, and higher order cortex motor dissociation. A meta-analysis found that across 25 studies, there was a wide range of patients who were reported to have covert consciousness. In some studies, this was as low as 8% of patients, but in other studies, as high as 71% of patients had covert consciousness, despite the fact that they appeared to be in a coma. On average, about 32% of individuals who were included in this meta-analysis had evidence of covert consciousness. That was 156 out of 592 patients that were included in the meta-analysis. Because of this difficulty in describing the states of disorders of consciousness, it's important to note that the taxonomy to make these descriptions may need further modifications, as perhaps there are much more detailed aspects of consciousness that have not previously been explored or described. Initially, descriptions of consciousness were based on the clinical phenotype. However, additional assessments can include more detailed testing of brain structure, including CAT scans and MRI, or brain function, including an EEG, an fMRI, and a PET scan, such that with all of this data, it may be possible to identify that there are various endotypes of consciousness, so descriptions of disorders of consciousness in a much more detailed manner than was previously the case. Finally, when thinking about patients with disorders of consciousness or coma, it's important to note that there are a number of different aspects that impact their identification, evaluation, intervention, exploration, prognostication, and limitation of therapy. These include religious considerations, psychosocial considerations such as race and ethnicity, social status, any bias or morale or burnout of the providers involved in their care or their families, language, healthcare literacy, and communication, Financial considerations also impact the care of these patients, including the gross national income or per person in the country that the patient is hospitalized in, insurance status, availability of expertise to care for the individual, and resource availability and allocation. Legal and regulatory considerations also impact the care of comatose patients in terms of the existence of protocols, laws on autonomy and equity, and laws on limitation of therapy. Cultural considerations, including the clinician-family power dynamics and institutional culture, can also impact the care of patients who are comatose. There are a number of potential ways to improve the diagnosis and management of disorders of consciousness when thinking about patients who are comatose. This could include advocacy, education, clinical care, and research. From the advocacy perspective, it's necessary to promote equity and access to expertise and resources, partner with disability advocacy groups to improve care, promote creation of laws and policies to prevent, manage, prognosticate, facilitate placement, and ensure care is equitable, prevent, assess, and address moral distress for both healthcare professionals and families. Education is needed to improve awareness of the impact of financial, legal, and regulatory, cultural, religious, and psychosocial considerations on patients with disorders of consciousness, and to disseminate relevant, understandable information about disorders of consciousness to the general public. Further research is needed to improve awareness and understanding of patients with disorders of consciousness. This requires harmonization of existing data sets, development of registries where none exist, and establishment of international clinical trial networks that include patients in all phases of care along the spectrum of care. The Curing Coma campaign is working to facilitate each of the improvement in each of these areas to promote improved awareness and advocacy, education, clinical care, and research of patients with coma. Over the course of the rest of this day, you'll hear a number of other presentations about these aspects of the care of comatose patients. Thank you so much for your attention.